Good evening, everyone. On behalf of the Indian Psychiatry Society Faculty Development Subcommittee, in collaboration with IPS PG Education Subcommittee, IPS South Zone PG Committee, IPS UG Education Subcommittee, and the Indian Teachers of Psychiatry, I extend a very warm welcome to all our esteemed office bearers, distinguished faculty members, PG residents, practitioners, and participants joining us from across the country. It is my privilege to welcome you all to today's panel discussion on implementation of NMC MD Psychiatry PG appraisal form in Indian medical institutions. I am Dr. Simran Sandhu, Executive Editor of Minds Newsletter, currently working as a Senior Resident in Department of Psychiatry at Gandhi Medical College, Bhopal, and I have the privilege of serving as the moderator of today's session. Before we begin, let me briefly introduce today's topic. The NMC's competency-based PG medical education framework has brought a significant shift in PG training with greater emphasis on continuous assessment, meaningful feedback, and competency development. The NMC MD Psychiatry PG appraisal form is an important step in this direction. It is designed to support formative assessment and foster learning, mentorship, and personal growth throughout residency. Today's discussion will focus on its implementation, opportunities it offers, the challenges departments may encounter, and the best practices for making it an effective educational tool. With that, let me introduce our distinguished panelists. We are honored to have with us an eminent panel of experts who have contributed immensely to PG psychiatry education and faculty development. Allow me to introduce Dr. M. Kishore Sir, Chairperson of IPS Faculty Development Subcommittee, Dr. Hinal Shah Ma'am, Co-Director of GSNC FAMER, Dr. Naresh Nabnani Sir, Co-Chairperson of IPS PG Education Subcommittee, Dr. Padma Sudhakar Sir, Chairperson of IPS South Zone PG Committee, Dr. Ayman Paul Ma'am, Convener of IPS PG Education Subcommittee, Dr. M. Bhargav Sai, Psychiatry PG Resident from JSS Medical College, Mysuru. Unfortunately, Dr. Anil Nischal Sir could not join us today as he is traveling. A very warm welcome to all our esteemed panelists. Before we proceed with today's program, I would like to acknowledge the gracious presence of Dr. Vinay HR Sir. On behalf of IToP, I would request Dr. Vinay HR Sir, Professor and HOD of Siddhganga Medical College, Tumkur, to kindly share a few opening remarks with the audience. Sir, please.
Yeah. Thank you, Dr. Simran. Sorry for traveling if the voice is breaking, but still, Indian Teachers of Psychiatry, which the initiative began in 2013, has become a platform for passionate teachers of psychiatry in India to share their resources, the inputs, so that will benefit in undergraduate and postgraduate medical education, and in turn enables them to serve the public in general. So in this regard, this particular session is all about MD Psychiatry appraisal form, which is a kind of a formative assessment, which needs kind of a discussion from the panel of experts, wherein we'll listen to their inputs, and hence Indian Teachers of Psychiatry is supporting this kind of initiative. Hopefully, we'll have a fruitful learning session. Yeah, best wishes from the Indian Teachers of Psychiatry. Thank you. Over to you, Dr. Simran.
Thank you so much, sir, for your warm regards. Before inviting our panelists, let us briefly look at the appraisal form that forms the basis of today's discussion. Kindly allow me to share that. So this is a structured formative assessment tool developed under the National Medical Commission's competency-based PG medical education framework. It is designed to facilitate continuous assessment and meaningful feedback throughout residency. As you can see, at the top of the form, there is a rating, 9-point rating scale. 1 to 3 signifies less than satisfactory, 4 to 5 satisfactory, and 7 to 9 means more than satisfactory. In addition to the numerical rating, the form also has a column for specific comments, emphasizing that the assessment should be accompanied by constructive and specific feedback. This has mainly three domains. First one is scholastic aptitude and learning, which evaluate residents' academic development. It assesses knowledge appropriate for level of training, participation in academic activities like journal club, CME, or seminar, involvement in research and scholarly work, documentation of logbooks or other acquisition of competence documents, performance in work-based assessment, and self-directed learning. The second domain focuses on care of the patient. It includes ability to provide patient care appropriate to their training level, ability to work as a team member, ability to communicate appropriately and empathetically with patient, family, and caregiver, ability to do procedures appropriate for the level of training and their assigned role, ability to record and document the work accurately, and participation and contribution to healthcare quality improvement. Now, the third domain is professional attributes, which includes responsibility and accountability, contribution to growth of learning as a team, and conduct that is ethically appropriate and respectful at all times. The appraisal concludes with a section for additional comments, allowing assessors to provide individualized feedback beyond the numerical score. Finally, the disposition section, which documents whether the appraisal has been discussed with the trainee, reinforcing the importance of feedback as an integral part of learning. The form concludes with signature of both the assessee and the assessor, ensuring transparency and shared understanding of the assessment. With this brief overview of the appraisal form, I would now like to invite our designated panelists to share their perspective on its implementation, feasibility, and the way forward in PG psychiatry training. May I now invite Dr. M. Kishore sir. Sir, as someone who has played a pivotal role in advancing competency-based psychiatry education and faculty development in India, how do you envision the NMC PG appraisal form transforming PG training in psychiatry?
Thank you, Dr. Simran, and my respects to all the dignitaries who are joined this session. And I would also like to bring the greetings from the Indian Psychiatry Society, the president, vice president, the secretary, the editor, and the treasurer also have conveyed that this is an important task for the psychiatry education because they are all in the program which is related to the practice guidelines at Jaipur. They have not been able to join online, but they have conveyed that this is important and this should be progressively involve all the stakeholders, and we should be able to utilize it to the best. That's one part. The second is Dr. Anil Nishchal, who is the chairperson of IPS PG Education Subcommittee. He also spoke because he had to travel, which was unplanned. He said that he will miss, and he conveyed his message that both IPS PG Education Subcommittee as well as the IPS Faculty Development Committee, we are together that this document, which is available in the NMC guideline 2022, that is the latest guideline, we are able to utilize it to the best. The beauty of this document is there is both qualitative and quantitative method of assessment, because in each section, when Dr. Simran was saying about scholastic issue or the care of the patient or the professional attitudes we expect, or some of the components which the faculty want to add, there on the side columns, after less than satisfactory, satisfactory, and more than satisfactory, there is also a section called comments. So a qualitative data can also be incorporated in the feedback. And we personally think that both the committees decided that this should be used at least once in 3 to 4 months, so that in a year there are at least 3 appraisals, 3 or to 4 appraisal, and the student is able to utilize it for improvement. And faculty is also aware where the emphasis should be, And we personally think that everybody in the department, whether it is senior resident or the assistant professor or associate professor or the HOD, everybody should play an active role in discussing and implementing the components. And in the assessment, I think if more people have opinion, it is much better. So this is one wonderful document, and it also gives scope about where to discuss and whether the student also agrees with certain aspects which are being told. Ultimately, it is to improve the postgraduate education. So in that way, this is a very nice document, and we should start using it. And as the faculty use this document, we will come to know what exactly we should add. But since there is a column that the faculty can think about those aspects which are not available in the thing can also be incorporated, I think there is scope for improvement from that end also. So, on behalf of all the faculty development committee members, advisors, we think that this document should be used to the fullest extent. And Dr. Nalin Nishchal from the PG Education Committee also has said that we should request all the 800 plus institutions in India, especially those who are training postgraduates in psychiatry, whether they are doing for DNB or MD, should use it. And I think this is a fantastic panel discussion now, since we have experts from medical education, experts who have experience over years, and also we have postgraduate representatives because they are also stakeholders. So it is an amazing combination. And Dr. Naresh, who is also from All India Institute of Medical Science, which is outside the scope of NMC, but they can also discuss whether this document is useful for INI's institutions of national importance. So, Dr. Simran, this is from my end, and I think it's a wonderful beginning. There's a lot of learning process ahead, and this is just a beginning. We should start using it, is what I suggest. Over to you, Dr. Simran.
Yes, sir. Thank you so much, sir. These were some very valuable insights and an excellent way to set the context for today's discussion. So, after we have seen the basic format of the appraisal form and we have seen how and who should apply it, I now invite Dr. Heenal Shah, ma'am. Ma'am, as an expert in medical education, what are your thoughts of this appraisal form and what factors are essential for making it an effective education tool? Please.
May I share? I've got 10 slides which I would like to share if you allow me to. Thank you for having me here. And I agree with everyone who has said that this is so important and we should be discussing it because it really helps us to take our level of appraisal to the next part. And as Simran has said, there is a curriculum that has come in the competency base in 2022, and it has multiple competencies, whether it is, knowledge, formulation, risk and capacity assessment, ECT, psychotherapy, communication, and it also talks about formative assessment should be done continuously for all the domains, and it says there should be quarterly assessment. All this is given in that document, and I'll try and share it in the chat box as soon as I finish speaking. And there is an appraisal form. Now, this appraisal form is a generic appraisal form. A similar appraisal form is there in pediatrics, and I think in one or few others. There are, again, different kinds of, but generic forms available in medicine, surgery also. But this exact form I've also seen in the pediatrics one. So now and Simran just shared this form that is there and told you about it, so I need not go back into this. But taking ahead, it is a very good and a generic form, and the people who have created done a good job. How can we use it and how can we use it most effectively? So few suggestions from my part. The curriculum is very good. I think it has those competencies and everything very good. But when it comes to assessment, it's very broad and vague. For example, it talks something like patient care, no? Appraise provide patient care which is appropriate. What does appropriate patient care really mean? While the competency document describes so many things, when you go to assess it, there is not enough representation. So there is under-representation, and therefore it's a validity threat. And the way ahead is to include some specific competencies, not all, and we'll come to that. And we should have blueprinting. Blueprinting tells us what are the topics and which are the ones that are going to be assessed. And so that gives you an idea whether you're covering the assessment well. That's the first thing I think that we really should do together. Second is the response. It says 1 to 9, but what is 4 for me, maybe 5 for Simran, maybe 7 for, Dr. Dhavle who's here. So everybody would interpret it differently. So what are the behavioral anchors have to be described? What does 1 mean? What does 2 mean? What does 3 mean? So then we are all on the same page. And to prevent that subjectivity, the faculty development is important and the assessors have to be calibrated. And that's really the realm of the faculty development IPS people. The third thing, they're saying appropriate to the year. Again, what is appropriate to the year? You have to add descriptors, what is expected at the first year, second year, third year. Don't leave it for each institute to interpret it as they want. When we develop a curriculum and we develop an assessment, we want it to be pan-India and we want to be the same thing pan-India. So therefore, you need to add a little descriptor to that. Now, I may say that I have seen my residents today and I've graded them, and some are 5, some are 7, some are 2. But how did I reach that? That is not said anywhere. How did I reach that? Is it because I've generally observed them? Have I done a test? On what basis am I grading? So there is no mention of that evidence. I personally felt there was a lot of emphasis because the whole first part is on academic, such as, does the logbook, does this, does that, all that. It's a little bit more also include things like clinical reasoning, shared decision making, would make it a little more balanced. And finally, while they give comments, I would go one step ahead and talk about structured remediation. And what does it really mean? And I've got just a few slides. And if I'm shooting over time, please let me know. So as far as competencies, of course, they've said those 3, but I'm saying clinical assessment, patient management, communication, teamwork, scholarship and learning, and professionalism. And then there are 100+ competencies that are already given in that curriculum. Should we assess each competency? Never. That is not expected in a programmatic assessment, that we assess all competencies. You have to choose and maybe pick up a few competencies. For example, I personally feel maybe say 12 competencies like this would be important. Say assessment and diagnostic reasoning, patient management, risk assessment, procedure like ECT or something. And there are different ways of assessing that. One of the commonest for history and all is just observation. And then, of course, there are other work-based tests or multi-source feedback or mini CX or any of these workplace-based assessment methods. So we have to choose which competencies. And I think the IPS PG committee can have this task force, can maybe decide with maybe Delphi system or whatever way they want to do it, decide which competencies should be included in this. So everybody is assessing these basic competencies for sure. Year-wise, maybe first 6 months performance of these competencies under direct supervision. End of 1 year, manage routine cases. End of year 2, manages common cases and recognizes complexity. End of year 3, manages routine and selected complex cases and supervises juniors appropriately. So I think these kind of descriptors, and again, this I've written today with very roughly, but you can understand that something like this, and the PG committee can in its wisdom discuss this and decide what needs to be done. Next, I said, how do we decide what is 1, what is 9? So you'll have to put behavioral anchors. One is the work is unsafe, he is very seriously doesn't know and cannot do it even if people are supervising. There could be 3, which is below expected level and requires more supervision. 5 could be minimum expected standards. 7 would be frequently expect better than the expected standard. 8 is highly proficient and can manage complex situations. And 9 can be exemplary and can support juniors. Again, the first 3 would be less than satisfactory. 4 to 6 could be satisfactory. 7 to 9 could be more than satisfactory. While I put this up, again, this is something to be reviewed by the PG committee and decide anchors. But what I'm trying to say, you need to have this so the subjectivity for the person who's marking it decreases, or inter-rater reliability improves, validity of this improves. How did you rate that? On what basis did you decide that person gets 4 or 5? So, for example, if it's teamwork, maybe you got feedback from the nurses, social worker, team members. So you did a multi-source feedback. Or if it was risk assessment, you observed them while they were talking to a patient who was suicidal. Or you did a mini CX, which is some kind of workplace-based assessment. Or you had a case review, chart review, how he has done it. So there has to be somewhere where you're doing it. It's not out of your hat. And that's why you should leave things like that if you have not observed, you can't really be sure how well you've rating it, or if there is insufficient evidence, or it's not applicable. This person has never had the opportunity to do that, and therefore I cannot comment on all of this. I think we should add a column, and this is an entrustment column. What does that mean? I think this is very instinctive for all of us who are teaching, that when the person comes, okay, you do this, but you only observe. Next time you do it under my supervision. Even when they're taking a history, the first time they just observe us. The first 15 days to 1 month is observation. Then they do it with, one of the seniors or the lecturers seeing them. Then they perform that history taking, with most of the supervisor present. If required, they will interfere. Otherwise, the person can do it. Then the next stage is they go perform with the supervisor around, but not necessarily looking at him all the time. Then they do it routinely for routine cases. Then they can do it independently in routine and some complex cases. And finally, you would trust them to do it independently and supervise juniors. So I think you should be able to also peg it how much trust level you have on them, because this really tells us how the person is progressing. The last bit that I'm talking about, how confident are you in rating this? You feel that there is limited observation, so whoever looks at it knows that, not had a chance to observe, but from my thing, it's rated like this, high, because I've seen him or her very often. The last thing, what is structured remediation? While it's very good that they have given a column, I'll tell you most of the time what will happen. Good, better, can do better. What does that mean? Doesn't help. And very often, even while, circling, most people will follow medium. They will not go too low, not go too high, or it will be a halo effect. Once they've done well, everything will be marked well. So to prevent all of that, we need to be having those behavioral anchors, and for remediation, be very specific. What went wrong? What was the task? What can you do about it? Where will you read it? By when will you read it? How will I assess you again? And then I'll check whether you've improved or not improved. So a little bit more effort on the feedback and the remediation. Only then we're sure that the person has improved. So I think in sum, what I'm trying to say is that maybe along the way we can think of changes. Competencies, we said we can choose at what level depending on first, second, third, rating 1 to 9 with anchors. What is the evidence, from where have you gathered? It can be as simple as observation. In most of our OPDs, we are observing. And you can just do that observation as a method of rating. You don't have to do all these mini CX and workplace-based assessment really came up because they found that most of the times the consultants had not observed and they were rating. And therefore, but in a OPD like ours, I know that my resident sits with me while taking the history every day. So I'm observing, and therefore I can tell from where I'm getting this information. The entrustment, which I said, whether has to be observed all the time to completely left alone. What is your confidence in this rating? And any other comments. And so my next part is only that the PG committee can work on the form, the faculty development can do the training, and I would advise the research committee to do some research. And in fact, recently ICMR NMC grant has come up for people who want to do research in the field of education, especially with all these new things NMC has come out. So they've just announced a grant for that. And I think IPS can work with all these three committees and think of doing that and pilot it and see if it is scalable. That's my 2 pieces of advice. And with that, I end. Thank you.
Thank you so much, ma'am. I think that's a very important point. The inclusion of year-wise descriptors and all the changes that you have mentioned would make the appraisal process much more structured and ensure that expectations are appropriate for each stage of residency. Thank you so much, ma'am. Now, before proceeding further, I would like to say that all the audience, they should post some of their questions or any queries that they are having in the comment section. We will take them up during the audience interaction round. Now, moving further, I would like to invite Dr. Padma Sudhakar sir. Sir, educational reforms often look ideal on paper, but evolve different in day-to-day practice. As departments begin using this form, what changes do you hope to see in the culture of PG psychiatry training for both residents and as a faculty?
In the first place, good evening to all the fellow panelists, and of course, Dr. M. Kishore, who is really doing good work in this particular field. And thanks to NMC that we are at least having a structural assessment program for the PG education and training. Unfortunately for me, I completed 70 years and out of the PG education.
Sir, we are not able to see you. Your video is off.
My video is very unstable. That's why
Okay, sir. Okay, sir.
So unfortunately, I'm out of PG education now. I'm only doing a consultation practice. But in fact, I had been in PG teaching almost right from 1986 till I retired last